about 35% of people who died without any symptoms of Alzheimer's disease at all, when we look at their brains at autopsy, they have those plaques. I'd say 20 years prior to the expected symptom onset, we start to see the aggregation of some of these proteins in the brain, some of these biological changes. You could be a 75-year-old running a corporation, and you're a lawyer, and you're great at crossword puzzles. You don't forget anything. You don't repeat yourself. You don't leave the stove on. Completely cognitively healthy, but your brain could have Alzheimer's disease. We have medications that were FDA approved for the last 5 years or so that can clear those plaques out of the brain. So technically speaking, we've cured the disease, yet you still have symptoms of the disease, and you're still declining your symptoms are still declining. So we're in a predicament, right?
Is there any hope to potentially restore the memories lost from these diseases? Have you ever wondered why forgetting something feels different as you get older? Is memory loss a normal part of aging, or is it the beginning of a disease? What if Alzheimer's doesn't just suddenly appear, but silently develops over decades? These questions force us to rethink how changes happen in the brain and how much of it occurs before we're even aware of it. Hello, I'm Avnish, and this is The Early Perspective, a podcast where we explore how the brain works, how it changes, and what that means for how we learn, think, and live. Today, we're going to be diving into one of the most important and urgent topics in neuroscience: Alzheimer's disease, aging, and neurodegeneration. Alzheimer's is often discussed as a disease of old age, but research now shows that its biological roots can begin decades earlier. Understanding how the brain ages, why it sometimes degenerates, and what we can do about it is one of the biggest challenges facing neuroscience today. I'm incredibly excited to welcome today's guest, Dr. Adam Brickman. Dr. Brickman is a professor of neuropsychology at Columbia University, where he works at the forefront of brain health and aging. A specialist in the study of Alzheimer's disease, Dr. Brickman seeks to understand how and why our brain changes as it gets older. Rather than just sticking to a single lane, he uses a 360-degree approach to study the mind. By combining advanced brain imaging with epidemiology and basic neuroscience, he maps out complex factors that influence memory and cognitive function. His goal is to bridge the gap between high-level laboratory research and the real-world experiences of those navigating cognitive aging and Alzheimer's disease. I've always personally been fascinated with neurodegenerative disorders because I looked at potential treatments for them in my paper, so I'm especially excited for this episode with him and for him to guide us through this discussion. Dr. Brickman, thank you so much for joining me here today.
Thanks for inviting me to be here.
Of course. My pleasure. So before we begin, I just want to go back to the beginning. Could you tell me a bit about your journey into neuroscience and especially aging research?
Sure. I mean, I think like a lot of scientists, I kind of retroactively can create a narrative that makes a lot of sense. The reality is that it started with an interest in psychology, and I think that like a lot of people who end up being psychologists, I was interested in human behavior. I think I'm very sensitive to dynamics between people, and when I walk into a room, sometimes I feel like I'm absorbing a lot of different energies from different people, and that was early on when I was in college. That was something that I wanted to explore intellectually and academically. I was also pretty good at science in high school. I wouldn't describe myself as passionate about science, but when I got to college, I discovered the field of neuroscience, and I ended up being a double major in psychology and neuroscience. And where I went to college, we had these either summer or winter term projects that we could do, and I found myself working one summer in a clinical setting at NYU with a neuropsychologist. And what I found was that there's an applied field that combined neuroscience, our understanding of the brain and neurons and the nervous system, with psychology, our understanding and study of behavior. And that field is neuropsychology. And what I learned was that we could use the tools of psychology to understand what was going wrong with the brain. And that was kind of mind melding for me, or mind exploding for me, because in my mind, neuroscience and psychology were two very different disciplines. And then how I got involved with aging and Alzheimer's research. Well, first it was an academic interest. Again, in college, I sort of was interested in neurochemistry and some of the big hypotheses about Alzheimer's disease. And then after college, I needed a job. I thought I wanted to go to medical school or a graduate school, and I applied to 100 different jobs. I wrote. It was even before email. I wrote letters to a lot of different professors and a lot of different medical institutes, and the job I happened to get was in an Alzheimer's center, and I interacted a lot with patients with Alzheimer's disease, with a lot with people who are older adults, and it really just resonated with me. I really enjoyed the interactions. I really saw firsthand how devastating dementia and Alzheimer's disease can be to people's lives and families. Um, you know, that was back in 1996, and here we are in 2026, and I'm essentially doing a version of the same job that I had right out of college, and it was never a question that to me that I wanted to pursue that.
Yeah, that's wonderful, Bad. Thank you for sharing that, first of all. And then, so now that we've established some introductions, could we just get into the basics? So, specifically, what does it even mean biologically for a brain to age? Because a lot of our listeners don't have any background in neuroscience. So, aging is just a term that's thrown around everywhere. But what does it even look like in the brain?
Yeah, it's a really really great question, and I would say that our understanding of what happens with the brain as it ages is limited by our ability to study our different tools that we have to study the brain. So every day we're learning something new, and my answer 10 years ago would probably be different from my answer today. And a lot of that is driven by how the approaches we take to understanding the brain. Generally speaking, age is just the passing of time, right? And so it's not a thing that we measure, right? And so as time passes, like any organ system in our body, there's a certain amount of wear and tear that our brain experiences over time. And a lot of that is due to vascular changes like hardening of our vessels and how blood is delivered to the different parts of the brain. A lot of it is due to different exposures to toxins and environmental exposures, our diets, et cetera, et cetera. But like any organ system, with the passing of time, our brains become a little bit less efficient, a little less uh, quick at processing information. And how that manifests is it loses volume. We lose the volume of gray matter, which is where all of our neurons or nerve cells hang out. We lose the volume and the integrity of the white matter, which are the fatty sheaths that allow the different parts of our brain to communicate with each other with great efficiency. We lose a certain amount of blood flow and metabolic activity in our brains, and these changes that uh, uh, happen to some degree with everyone, but there's a lot of variability in how much our brains age across different people. I don't know if that answers your question. Of course,
Yeah,
there are a
it
lot of
does.
diseases that also emerge in the context of age, and I'm sure we're going to go there, like Alzheimer's disease
Hmm.
is a disease. It's not a normal part of aging, but it is something that happens in the context of aging.
Hmm. So you mentioned variation. Could you tell me more about that? What's causing this variation to people who are the same age, but they're seeing maybe even different volumes of gray
Yeah.
matter and white matter in their brain?
Yeah, that it's one of the great mysteries of aging research, right? And I think everyone who's met a number of older people see it not only in their brains, but also in their physical strength, their even how they look, their appearance, how they move, how quickly they think about things. So the reality is that things like our thinking abilities, our processing speed, how our brains look. If you take a group of 25-year-olds, there's a lot less variability between people in those different things that we measure. And as people age, that gets greater and greater. So clearly, there's a genetic component to that. But there's also a lot of other factors that contribute to how our brains and our thinking abilities age. And some of that is, like I said before, our overall health, vascular health, the activities that we do throughout our lifespan, um, sleep, all sorts of different behaviors. But a lot of it is genetic, I would say, the variability in how we age.
Okay, great. So while we're already just establishing some basics, what exactly is neurodegeneration?
Right. So neurodegeneration is a very, very general term. It basically just refers to the dying of nerve cells or the dying of neurons. So we operationalize or we define neurodegeneration a lot of different ways. We'll look at the shrinking. If we're talking about humans, we can look at the shrinking of different parts of the brain using technologies like magnetic resonance imaging or MRI. If we're talking about animal models, we can or postmortem tissue, we can look under the microscope and actually measure the density of the neurons or markers of neuronal death. And so essentially neurodegeneration is the dying of nerve cells, oftentimes caused by certain diseases or certain insults to the brain.
So, an example of a neurodegenerative disease is Alzheimer's, of course, right? So,
Right.
how exactly is that different from dementia? I know that both of those terms just get thrown around together sometimes. So,
Yeah.
where exactly is the line between them?
It's a really, really great question, and it's an important question that a lot of people struggle with. And I'll say, being in the field now for 20 plus, almost 30 years, or maybe 30 years, um, um, how we talk about Alzheimer's disease has changed a lot, and how we think about the disease has changed a lot. But generally speaking, dementia is a very general term. It means a loss or a change or a decline in cognitive ability that ultimately affects your ability to take care of yourself, your ability to work, your ability to do things around the house. So that's just a general term, dementia, right? And so dementia can be caused by lots of different things, and more likely combinations of lots of different things. Alzheimer's disease, which is a specific disease defined by these protein aggregates in the brain, we can get into that, is one of the causes of dementia. It's the most common cause of dementia, and that's often why they're used interchangeably. Usually when someone has dementia, it's caused at least in part by Alzheimer's disease, but not all dementias are caused by Alzheimer's disease, and dementia doesn't specifically mean Alzheimer's disease.
Yeah, I think that's an important distinction because even a lot of people who just see dementia, they might automatically associate it with Alzheimer's, but then there
Yeah.
is a line between them, right? So then specifically for Alzheimer's, what exactly does it look like in the brain? What's happening in Alzheimer's?
Right. Well, there are a lot of things that happen in the brain of someone with Alzheimer's disease, and there's a lot of debate in the field about how we should define Alzheimer's disease. Classically, Alzheimer's disease is defined by the accumulation of these two protein aggregates. One is called beta amyloid protein, and we sometimes call them amyloid plaques. And these are strands of proteins that get clumped up outside of the neurons, outside in the extracellular space. The other hallmark pathological feature of Alzheimer's disease is something called neurofibrillary tangles, and these are made up of tau protein, and these are proteins that aggregate within the cell and cause damage to the neurons from the inside out. And so, classically speaking, Alzheimer's disease is defined by the presence of plaques and tangles, these two protein aggregates. Now we can measure those now in someone who's living. When I started in the field, we could only measure those plaques and tangles when someone was dead by looking at their brain tissue. Now we have different types of brain scans, like PET scans, to approximate where those different protein aggregates are in the brain. And we can use blood tests now, which is incredible, or we can look at the cerebrospinal fluid to measure those proteins circulating in those compartments and infer whether someone has those plaques and tangles in their brain. So that's the disease. Now, as someone with Alzheimer's disease progresses through the disease, we start to see a lot more of that neurodegeneration that we talked about before, shrinking of different parts of the brain that reflects the loss of neurons and other cells that support the neurons in the brain.
Hmm. Yeah, so how exactly are these plaques and tangles causing these symptoms that Alzheimer's typically presents?
That is a Nobel Prize question to be answered. We don't know. In fact, some of us
Hmm.
don't believe that the plaques and tangles are directly related to the symptoms of the disease. So there's a lot of questions. There are way more questions than answers in Alzheimer's disease. The reality is about 35% of people who die without any symptoms of Alzheimer's disease at all, when we look at their brains at autopsy, they have those plaques. So not everyone with the plaques has the symptoms of Alzheimer's disease. And we don't fully understand why it is that some people with plaques don't get the symptoms of the disease. We also don't understand why a lot of people who seem to have Alzheimer's dementia, they have cognitive impairment that affects their ability to think. It looks a lot like we would expect with someone with Alzheimer's disease. A lot of those people don't have evidence of those plaques. And so there's a lot of debate about, what is Alzheimer's disease, what's causing the symptoms, and how the symptoms emerge from some of the things that we can measure in the aging brain.
Hmm. Yeah. I think it's fascinating that there's so many mysteries, no
Yeah,
answers, but many
it is
questions.
it is a complicated organ, right? So the heart, no
Hmm.
offense to people who study or are interested in the heart, is relatively simple compared to the brain, right? So we
Yeah,
we
for
made a lot
sure.
more progress with the heart than we have with the brain.
Hmm. Okay, great. So now that we've established some basics, let's get straight into this conversation. One thing that people often confuse is the difference between normal aging and neurodegenerative disease. So, from a neuroscience perspective, what exactly is the difference between somebody just normally having memory changes versus Alzheimer's? Like, for example, if they forget some names or misplacing things, or start misplacing things, is that a red flag, or how exactly can you identify Alzheimer's starting in a person?
Right. So it's a very, very, very complicated question, actually. So let's separate the biology from the clinical symptoms. Okay, so let's
Hmm.
focus on the clinical symptoms first. So as we started off talking, we acknowledged that there's change in the brain with age. With those changes in the brain, we would expect some degree of cognitive or thinking abilities to change. And that's what we would call normative or normal, right? Like
Hmm.
everyone who ages experiences some degree of cognitive change. Clinically, what we try to understand is whether those changes in thinking ability reflect a normal process versus reflect something more concerning like the onset of dementia, right? And so we use something called neuropsychological evaluations. These are very structured cognitive tests that we integrate with a lot of other information about the patient, the person, to understand if the cognitive changes that we're observing are in fact normal or expected for someone's age, or if they're a little bit outside of the range for expectation. So we can assess those things very, very formally in a clinical setting. In terms of someone's experience throughout life and some people's experience with their loved ones, for example, when we start having concerns is if people are repeating stories, that they've already said, if they're getting confused, certainly around their home, if they're getting confused with um, with family members, who they are, recognizing people, leaving the stove on. Those types of things start to be a little bit more concerning when we hear people reporting those. So there's certain changes. We all have trouble conjuring up names of people, for example. As we age, that's something that I noticed in my 40s. I was used to be very, very good at thinking about an article, who the authors of the articles were, someone I knew well, and now that's something that's a lot harder for me. That's something that would be a typical aging change. Something that would be more concerning is if I, repeated the same story to you during this conversation that I told you 10 minutes ago or so, or if you asked me what I had for breakfast this morning and I wasn't able to conjure up that memory. Those are things that are a little bit more concerning. And in terms of the
So, what?
biology, though, if we can get into the biology a little bit,
Yeah.
so So I think we're going to get into this a little bit later. The biology of Alzheimer's disease, those plaques and sometimes those tangles, can occur many, many, many years before someone has any symptoms of the disease. Right? So the way we determine whether someone has potential Alzheimer's disease is by using some of these biomarkers that I told you about before. The PET scans, the assessment of the cerebrospinal fluid, or now some of the blood tests. We can estimate whether someone who's older has evidence of the biology of Alzheimer's disease, even if they don't have any symptoms of the disease.
Hmm. So, how early are these biological changes starting?
Right. So some of the estimates from particularly from populations that have genes that cause Alzheimer's disease, we know they're going to get Alzheimer's disease in the future based on their genetic profile. From some of those studies, up to like I would say 20 years prior to the expected symptom onset, we start to see the aggregation of some of these proteins in the brain, some of these biological changes.
Hmm.
And that, again,
So,
that's also variable. Some people it might be 5 years before they have symptoms. Some people it might be, I would say at most 20 years prior to symptom onset.
so what you're saying is the research which is supporting first the onset of Alzheimer's and also how early on, all of it is very almost blurred right now, right? There needs to be a lot more research done to find that definitive line because, as you said before, somebody who might have more severe memory changes could potentially have Alzheimer's, but that's again not a definitive marker of Alzheimer's, right?
Right. So the memory changes wouldn't be a specific marker of Alzheimer's disease. Some of these biological tests would be more
Hmm.
specific to Alzheimer's disease.
Right.
What I'm saying is that you can be cognitively totally healthy. You could be a 75-year-old running a corporation, and you're a lawyer, and you're great at you know crossword puzzles. You don't forget anything. You don't repeat yourself. You don't leave the stove on. Completely cognitively healthy, but your brain could have Alzheimer's disease, and that's very confusing for people to understand. That in some ways, it's a disease without symptoms until people
Hmm.
start showing symptoms or die. Right.
Hmm. So you're talking about the the component of Alzheimer's, right? How definitive is that as a marker of Alzheimer's in a
Yeah.
person?
So there are specific genetic mutations that are called fully penetrant. That means that if you have the mutation, you will definitely or almost definitely develop Alzheimer's disease. And that's very, very rare. Probably less than 1% or maybe about 1% of all of Alzheimer's disease is caused by a specific genetic mutation. There are three main ones. There's some rarer ones that are being identified more recently, but the genetic mutations are presenilin 1, presenilin 2, and APP. Those are the three big genes that are causal for Alzheimer's disease. People with Down syndrome, also because of the triplication of their 21st chromosome, also are genetically programmed, if you will, to develop Alzheimer's disease. On the 21st chromosome, we have that APP gene, and so people with Down syndrome overproduce the amyloid protein, and it causes Alzheimer's disease in the vast majority of people with Down syndrome. So those are generally speaking the genetic forms of Alzheimer's disease. APP, PS1, PS2, and Down syndrome are the four genetic causes of Alzheimer's disease. In the vast majority of people with Alzheimer's disease, we often call it sporadic Alzheimer's disease or late onset Alzheimer's disease, which is an acknowledgement that we don't understand the genetic causes or the combinations of the genes that are causing that disease. There's surely a genetic component. There's some genes that increase risk by a lot, like the ApoE gene, but they're not causal single mutations.
So what about other factors like education, cardiovascular health, sleep, or exercise? How much uh, of a factor do those play in Alzheimer's and its onset?
Yeah, that's a really, really great question. There's obviously we sometimes call these sort of modifiable risk factors, right? So are these things that people that contribute to Alzheimer's disease or dementia, and are these things that we can intervene on to mitigate the risk of Alzheimer's disease or dementia? So all the things that you mentioned, vascular disease, sleep health, diet, metabolic disease, all these different factors are all risk factors for sure for dementia, right? So all these things contribute to our risk of developing dementia. We said before, dementia is just this like general category. There's a lot of question about, well, does it actually help, or is it in the causal pathway? Are these things in the causal pathway for developing those plaques and tangles? We're not sure about most of them still, but there's no question about it that what's good for your body is good for your brain. So if we can do things like keep our hypertension in check, or not develop hypertension, not develop diabetes, have good diet and exercise. All these things might mitigate the risk of developing dementia. It might not cause prevention of those plaques and tangles, but it might mitigate the effect of those plaques and tangles on someone's behavior or cognitive abilities.
Hmm. So, is there anything else that people can do to actively kind of protect their brain?
So, I mean, the things that we tend to tell people from a public health perspective is a lot of things you covered already. Keeping your vascular health uh, uh, is healthy as possible, as much as we can control that. That to me would be on the top of the list. Others, what we tell folks is trying to stay socially engaged, trying to stay cognitively or intellectually or engaged. Certainly diet, exercise, movement, social engagement. These are all things that are important for our health in general, and certainly for our brain health as well.
Yeah. So, I know your research looks closely at brain structure and how it relates to memory and disease risk. So, which brain regions are especially important in aging and Alzheimer's, and why?
Yeah, the why is still a big question. So the brain, uh, we can think about the brain as a single thing, but it really is a very complicated organ that comprises multiple parts that are interconnected, right? And so, in terms of Alzheimer's disease, it appears that a lot of the pathology, the early pathology, particularly those tangles, uh, start or very early on in the disease are in what's called the medial temporal lobe, which is sort of in if you drew a line from your ear going in, there's a structure in there called the hippocampus. The hippocampus seems to be very, very important for memory. Around the hippocampus, there's another structure called the entorhinal cortex. And in parts of the entorhinal cortex, that's where we see some of the earliest deposition of those tangles. And that the amount that the entorhinal cortex and the hippocampus are involved seems to predict or be related to the amount of cognitive or memory symptoms that are involved. So certainly the medial temporal lobe and the hippocampus are very, very important in Alzheimer's disease. Typically, when we're talking about cognition that's changes with normal aging or other neurodegenerative diseases like frontotemporal dementia, we might be talking about the frontal parts of the brain, the frontal lobe, which seems to control things like executive functioning, working memory, some aspects of language, etc. So we can think about the brain as working together, but each one of those nodes in the brain sort of have a specialized role in different thinking abilities and different body functions and different sensory and processing abilities. I use MRI scanning to look at some of the vascular changes in the brain. And so my laboratory focuses a lot on some of the insults that the brain experiences with age that reflect disruption in the vascular system or the blood vessels in the brain. So there are other things we can measure in the brain that don't reflect just the structure of the brain itself, but some of the function of the brain and some of the damage that the brain has experienced due to all sorts of different insults.
Hmm. Right. So, you mentioned that the hippocampus and the medial temporal lobe are such key players. So, what makes them such key players in memory decline specifically?
We don't know. I mean that the we know that the hippocampus and the entorhinal cortex are involved with creating new memories and storing them to a certain extent. And so how for whatever reason that's how our brain evolved. And it recapitulates across different species. So the hippocampus involvement in memory is true in humans, and it is true also in mice and in fish. And so for whatever reason, that's how our brain evolved to support memory. Why it's particularly vulnerable to Alzheimer's disease? We don't know. It's a billion-dollar question. So we really have no idea. And I'd probably argue in the case of a lot of diseases, a lot of the brain, a lot of degenerative diseases at least, we understand that they affect different brain regions selectively, but we don't understand why certain regions are vulnerable in some cases versus others.
Right. I think the general pattern that I'm noticing is that current research, there needs to be a lot more progress in research to answer many of these questions. So,
Exactly. Yeah.
what exactly are the current approaches being done to study Alzheimer's and just in general the aging brain?
I mean, there's so many different approaches. I mean, people are very, very interested in just the behavioral aspects of what happens with aging, and that can be like cognitive studies. And a lot of people are interested in things that are maintained with aging or things that improve with aging. So there are a lot of different behavioral approaches. There are epidemiological approaches where people study large cohorts of groups of people to look more on a population or a community-based level, what some of the trends are over time and as people age. And a lot of those studies incorporate aspects of what we sometimes refer to the social determinants of health, or the structural aspects of our society that contribute to health. Um, there are obviously a lot of brain imaging studies. I love brain imaging, so we do use PET scans and MRI scans and other brain imaging techniques to understand what happens with the brain as we age. There are genetic studies, there are sequencing studies, there are pathological studies, there are histopathological studies, there are uh, a ton of animal studies, and the field is incredibly diverse, and there's a lot of expertise on all sorts of levels of reductionism when we think about the brain. So we could talk for 4 hours about the different types of research that's being done to study the brain aging.
Hmm. So, from your research, did you find that specific ethnic groups or any specific groups of people in general are more predisposed to getting Alzheimer's or any sort of neurodegenerative disorders?
Yeah, no, it's a great question. So I'm at Columbia University, and we're in the upper part of Manhattan, and we do a lot of community-based research. And it's a really, really great community up here in Washington Heights. And the community around the medical center comprises, generally speaking, I mean, there's a lot of diversity, but generally speaking, there are three main racial and ethnic groups that are represented. White people of mostly European ancestry. There's a large Latino community, mostly from Dominican Republic, but from lots of different areas. And then there's an African American or Black community. And generally speaking, what we find in our research is that people who are of Latino or Black backgrounds, generally speaking, are at greater risk for developing cognitive impairment or dementia as they age. And we're trying to understand the social factors and the structural factors that contribute to that increased risk in for dementia in those different racial and ethnic groups. What I can say, and some colleagues in the field might disagree with me, is that we don't think that Alzheimer's disease, those plaques and tangles, differentially emerge in different racial and ethnic groups. Rather, we think that it's the social factors that differ across these different racial and ethnic groups that are contributing to that differential risk.
Hmm. So, what kind of social factors are essentially kind of
At
contributing to
the top
this?
of the list is racism and all the effects of racism, and that interacts with educational access, educational experience, access to resources in the community, exposure to pollution, et cetera, et cetera. So all these things sort of interact, but I think the reason why we see them patterned by race and ethnicity, I think, has a lot to do with the long history of racism and bias in our country, and how that sort of perpetuates through generations and generations.
Hmm. So, I think that's a really interesting point that you're bringing up, that how racism could even play into this. So how is barriers to access to education, especially higher education, affecting potentially getting a higher predisposition for neurodegenerative diseases like Alzheimer's?
Well, you can. So again, we should distinguish between Alzheimer's disease and dementia or neurodegenerative diseases
Mhm.
or cognition, right? And so what we know goes along with education. Education is in some ways a marker of socioeconomic status, and socioeconomic status goes along with a lot of the health behaviors that we discussed earlier, right? So um, uh, health health access differs by how much education. Health behaviors differ by how much education people have. Health literacy, or what our understanding or our knowledge of what is healthy, quote unquote, or not healthy, differs by educational experience. Access to healthcare differs by educational experience or socioeconomic status. So all these things interact. The careers and the jobs that people have differ by socioeconomic status or education. All those things interact, and you can imagine a scenario where where all these things work together, and they differentially affect different groups of people. So then we start seeing differences in outcome in cognitive impairment or dementia risk across different race and ethnicity groups when they're really mediated by the social and socioeconomic uh, forces that correlate or go along with those different race and ethnicity groups.
Right. So what you're saying is that there is sort of an interplay between socioeconomic status, especially in how people are getting different accesses to healthcare and other factors, and all of these are together contributing kind of to people's overall like factors and their predispositions, right?
Exactly. Yeah. Yeah. That's a great way of summarizing it.
Okay, great. And then, so just looking ahead, what are the future advances and approaches that are currently being developed in research in the aging brain and neurodegeneration?
Yeah, I mean, I think when I entered the field, there was a lot of debate about, should we treat plaques, should we treat tangles, and I think there's an idea that if we can treat plaques or remove plaques from the brain, will cure Alzheimer's disease. We can do that now with medications, and it doesn't cure the dementia syndrome that goes along with Alzheimer's disease. So it's been a huge disappointment. It's been an incredible advancements in the field that we've developed the uh, uh, approaches to clear out the plaques in the brain. But what I think there's finally a reckoning in the field that Alzheimer's disease is much more complicated than just the presence of these two proteins, plaques and tangles. And so, what I'm most excited about is that there's more acknowledgement and more attention being paid to all the different factors that work together to promote not only Alzheimer's disease, the plaques and tangles, but the dementia syndrome that goes along with it. So I think in today, what I'm excited about is that the field sort of embraced the heterogeneity of the forces that contribute to cognitive aging and dementia, and is now taking a much broader approach, I would argue, to understand the different factors that interact with each other that we can ultimately prevent or treat.
Hmm. Right. So ultimately, as you mentioned, treating, how close are we to finding genuine treatments and that aim at curing the disease rather than just offering symptomatic relief? Because many of the current therapies are focused on mainly mediating the symptoms, not really curing the disease per se.
Right. Well, I'm going to push back a little bit on that, and this is where some of the problems are with our fields, right? So if we define the disease as, say, the presence of plaques in the brain, right, and in fact, many people in our field, that is the definition of Alzheimer's disease. You have aggregates of amyloid plaques in the brain. So now we have medications that were FDA approved within the last 5 years or so that can clear those plaques out of the brain. So technically speaking, we've cured the disease, because if we define the disease by the presence of plaques and we remove those plaques, then, logically, the disease is cured. In fact, if you take one of those medications and you have Alzheimer's disease, and then after being on that medication, you come to my office and I do a PET scan to see if you have those plaques, you won't. And you no longer technically meet the criteria for having the disease, right? Because the plaques have been removed. Yet you still have symptoms of the disease, and you're still declining symptomal. Your symptoms are still declining. So we're in a predicament, right? So we in some ways we've cured the disease, but we haven't cured the symptoms of the disease. I would be much happier if we completely cured the symptoms of the disease, even if people continued having plaques. So how far are we from completely curing the symptoms of the disease? That's hard to predict, right? If a lot of what happens in research that's focuses on the mind is serendipitous, right? So who knows? Someone might stumble on something. They're testing a drug that's supposed to treat, arthritis, and it doesn't treat arthritis, but for some reason, everyone who's older seems to look cognitively healthy. A lot of our psychiatric drugs were kind of discovered that way, right?
Yeah.
And you may have heard of even Ozempic was being tested for Alzheimer's disease because there's some evidence that it helped cognition in people
Right.
who are taking it, right? So that could happen tomorrow, right? That could happen a week from now. If we look at all the different hypotheses about different pathways that are being tested, it's really hard to predict. There's some drugs that are in development right now that show some promise, but I would say it's certainly on the order of years before we have one pill that we can give people to cure Alzheimer's disease. And I suspect it's going to end up being a very multimodal approach to treating and preventing the disease.
So when I was doing my research and writing my paper, I was particularly focusing on neurogenesis, or just the regeneration of neurons, as a potential treatment for neurodegenerative diseases. But
Yeah.
then I also looked at stem cell therapies, and then, as you said, anti-diabetic agents like GLP-1. And then there's also keto, which surprisingly offers some promising hope in potentially helping treat Alzheimer's and other
Yeah,
neurodegenerative
well,
diseases.
epilepsy in particular, right? So
Yeah. So then, what do you think is probably the most promising or offers the most hope in the future?
I think that there's a huge vascular component to both Alzheimer's disease specifically, and also to dementia in general, right? So I think that if we can get a handle on cerebrovascular disease and the health of our brain vessels, and that interacts with inflammatory processes, I think that that's going to be a pathway that might potentially help a lot of people, irrespective of whether it's Alzheimer's disease or another form of dementia or just cognitive aging. So I think that there are probably some big players in how the brain ages that if we can get a handle on those mechanistically, we might be able to have a higher impact across different conditions on people. And so, we're really focused on endothelial cells, uh, vascular vessels that help maintain what's called the blood-brain barrier, and they seem to be susceptible to different inflammatory processes, and if they're vulnerable, they'll result in some vascular lesions in the brain. And so I suspect if we can really get a handle on that, it'll be really helpful to people.
Right. So, especially you're saying understanding the mechanisms and trying to focus on that specifically could potentially be really useful in the future, right?
Yeah. I mean, I think you can sort of think about two camps. We can get very, very, very specific in the mechanisms, like we need to treat those plaques because they're specific to Alzheimer's disease, and if we do, that'll cure Alzheimer's disease. Or we could take a step back and say all of these different diseases of the brain as we age have some things in common. What are those things that are in common, and can we start targeting those to have a more general, impactful approach?
Is there any hope to potentially restore the memories lost from these diseases? Or is that just like neuronal death and then there's no potential to restore that?
There's always hope, of course. I think memory is a very, very tricky thing because I think when we think about memory, we think that, it's some hard drive in our brain where information is stored, and And, maybe in the case of Alzheimer's disease, we just can't access those memories as they're stored throughout the brain. And so certainly using that analogy, if there's a problem with accessing stored memory, you can imagine a scenario where some sort of a therapy or some sort of an intervention would facilitate our ability to access stored memories. But memory is really, when we have a memory, it's really a reconstruction of a lot of different pieces of information that are stored in a distributed network around the brain. And I think the general thinking is, once you've had the neuronal loss that affects those abilities, those different regions to interact with each other, then there's probably not too much of a pathway in today's world with our technology today that would allow us to recreate those memories with high fidelity. So really, the question is, the emphasis is on prevention of disease and on slowing down the progression of disease. Being able to reverse symptoms of the disease is obviously very aspirational, but that's like down the road. We'll figure that out
Yeah, yeah,
later, right?
for sure. Okay, so before we wrap up, I just want to end with just two quick questions. If listeners remember just one thing from this episode, what would you say that they should remember?
That is a great question. Uh, what's good for your heart is good for your brain. How about that? I don't. We didn't really talk too much about that, but that I think is really important. That
Right.
Alzheimer's disease and dementia are really two different ideas that are related to each other, but they actually describe two different things.
And then last question. Do you have any advice for any students interested in getting into medical research in this field specifically?
Yeah, I mean, I think curiosity and passion are the driving forces of a lot of emerging scientists, established scientists as well. And I think that there are a lot of people who do the work, myself included, who are always excited to share knowledge and just to tap into your enthusiasm and excitement and passion about science, and read as much as you can. There's a ton of information online. Get in touch with scientists, and if people are thinking about going to college, getting involved with research in college. I know a lot of high schools emphasize research programs now. That's one path that, I personally, I think that doing lab-based research is great in college. And high school, it's good to be exposed to some of those techniques and as well. But the work, I think, um, can be done, as people go to college.
Right. Okay, Dr. Brickman, thank you so much for joining me here today and for helping make such a complex topic actually seem approachable and meaningful. Alzheimer's isn't just about memory loss, it's really just how the brain changes across a lifetime and how science can help us understand, protect, and respect that process. For listeners, if this episode gave you a new perspective on the aging brain or anything about Alzheimer's, share it with somebody who would appreciate it. If you guys enjoyed this episode and learned something new, make sure to follow on your favorite podcasting platform or on YouTube. I'm Avnish, this is The Early Perspective, and I'll see you in the next episode.